excited to introduce today's ataxia expert, Dr. Pravin Khemani, who is a neurologist specializing in ataxia at the Swedish Neuroscience Institute Movement Disorders Center. Welcome, Dr. Khemani.
Hi, Lori. Can you hear me okay, Lori?
Yes, okay. Sounds great.
Okay. Hi, everyone. Lori, NAF colleagues, thank you very much for having me. And thank you all participants for spending your Friday afternoon with us. I will be talking about general aspects of ataxia. Just a couple housekeeping things. This is not a prescriptive lecture, and I'm not your personal physician, so it'll be a little challenging for me to speak to your specific symptoms. I'll do my best to answer as generically as possible. I'll try to address a wide range of questions that are popping up on the chat box. Obviously, the questions are popping up much faster than I can answer them. So there might be several questions unanswered, but this past week, I had the opportunity to review the previously presented lectures that are stupendous. I highly encourage you guys to go to the NAF website and listen to the lectures from my ataxia colleagues. There's about 7 hours of lectures already recorded, and I can bet you more than 90% of your questions are going to be answered between this session and those. So the very first question is from Joe, who talks about symptoms on his left side, and he has an unspecified ataxia. Well, Joe, although I treat ataxia, I'm also a neurologist. And when you have symptoms like this, you have to cast a broad net. And you have to think of neurological and non-neurological diseases that cause numbness, tingling, lightheadedness, and trouble with balance. Even people with ataxia can have other things going on. If your initial emergency room tests have all come back normal, that's actually a wonderful thing. But I would recommend that ataxia or not ataxia, when you have new onset neurological symptoms, it is very important to speak with your neurologist, who can do a thorough neurological examination history better than you can ever get in an emergency room. And I hope you get into a neurologist who can determine if these symptoms are related to your ataxia or are they separate from it. Autoimmune cerebellar ataxia is a question Michael asks. Can you speak to autoimmune cerebellar ataxia? There are two separate phrases over here. One is autoimmune, and the other is spinocerebellar ataxia. I'd like to unpack this question a little bit. There is a whole group of disorders called ataxias due to autoimmunity or immune-mediated ataxia, and then there is spinocerebellar ataxia. In the current lexicon, spinocerebellar ataxia refers primarily to autosomal dominant genetic ataxias, and these are usually not autoimmune. But if you have both, then it becomes a little bit of a complex management. Let's first talk about what are immune-mediated or autoimmune ataxias. Immune-mediated and autoimmune ataxias are typically not genetic. They're due to the immune system of the body attacking the nervous system and causing ataxias. These can be seen in the setting of cancers. They're called paraneoplastic ataxias, as cancers can produce certain antibodies that can attack the cerebellum, other parts of the brainstem, and the spinal cord. Early detection of these and treatment with various drugs is very important to prevent damage to the nervous system. So that is one group of immune-mediated or autoimmune ataxias. Celiac disease is an ataxia, or celiac gluten ataxia has an immune-mediated or autoimmune component. It's not very common in my clinical practice, but one detected when confirmed, it can be treated with a gluten-free diet and other immunomodulatory substances. if you have autoimmune ataxia along with spinocerebellar ataxia, those are two separate disease processes. The autoimmune ataxia needs to be treated separately than the spinocerebellar ataxia, which tends to be a genetic ataxia. And I hope I answered that question appropriately. Why is SCA12 not a part of any trial? There are many patients around the world with it. It's an excellent question, not just SCA12, but SCA10. Now we are up to 48 SCAs, I've been told. So there are several that are not part of the clinical trial. The decision to have a particular ataxia included in a clinical trial, for instance, the Biohaven trial, is dependent on many factors: availability of experts in the area, the incidence and prevalence of the ataxia. The current ataxias that are being studied are some of the most common ataxias in terms of their prevalence, and these tend to be the triplet repeat ataxia. It's a scientific term for the kind of mutation that causes these ataxias, and about 50% or 40% of the ataxias are accounted by triplet repeat ataxia. So I have a feeling that's why these ataxias are being lumped together to study them first in the Biohaven trial, for instance, which we are doing at Swedish and various other places. 1, 2, 3, 6, 7, 17, those are the ataxias that we are studying right now. But I can bet you when we are studying non-triplet repeat ataxias, there will be a place for ataxias such as SCA12. Let's see. Marty's question says something about once your balance is affected. I think that's part of a question. And they write, can you regain balance again? Yes, you can. Not only in cerebellar ataxia, but in strokes and multiple neurological diseases, you can retrain your brain to regain balance. Maybe not to the fullest extent of what it was before the insult or before the ataxia started, but there's plenty of evidence now that appropriate neurophysiotherapy, and it's very important that it needs to be neurorehabilitation, can allow your brain to train back and gain, retrain your brain and gain. I don't mean to rhyme, but you can gain your balance back, both static and dynamic balance. Is pneumonia vaccine effective for pneumonia caused by aspiration? Not necessarily. The pneumovax that is available currently is for community-acquired pneumonia. Pneumonia caused by aspiration tends to be due to different pathogens that this particular vaccine doesn't always prevent against. Curable treatment for ataxia, telangiectasia in United States writes Arun, no, not yet. It is being studied in clinical trials. And I just want to write this website down for everyone, .gov. If you have any questions about what studies are being done around the world, I love this website because it has many filters. This morning, I was looking at this website to see what's available in the US, in Europe, in Asia, in South Africa. This website has various tabs. You can go to the Maps tab, click on a particular country, and the list of trials, all trials that are registered with this website pop up. Using filters, and we can have a session actually. I was just thinking, Lori, maybe in the future we can have a session in which we can spend 10 or 15 minutes screen sharing and showing people how to access this particular website and go through it. And that might be something that people could enjoy. I don't think we may have time today, but if we do, I can screen share and pull up the website. Anyway, on this particular website, you can list the various ataxias being studied, put in keyword ataxia, and then you pick recruiting, non-recruiting, already recruited, completed trials, etc., and a whole list of trials pops up. If you're interested in ataxia telangiectasia, you can type that in, although it's a mouthful, and the trials that are dealing with compounds for ataxia telangiectasia come up. But right now, these are in clinical phases. They're not ready for prime time yet. I'm just scrolling up to look at Lee's question. Is whole genome sequencing better than whole exome sequencing for testing my mother's and my own DNA to identify her ataxia? And would it be beneficial to test both our DNA side by side to discover any possible de novo genes? What a stellar question. It is a great question, and it is a little complex in terms of the answer. First of all, are there symptoms? If there are symptoms of ataxia in both Lee and her mother, then that speaks to a familial or genetic ataxia. If you go to a neurologist, a movement disorder specialist, or an ataxia expert, just by examining you and your mother, they may be able to narrow down the possibilities where you may not need whole genome sequencing, which tends to be very expensive and not readily available. And they may be able to order a gene panel or even very selective genes based upon your phenotype or your presentation that you may not need whole genome sequencing or whole exome sequencing. Whole genome sequencing can look at the entire genome, and usually it's the largest fishing net you can cast in an ocean of genes. So you catch a lot of fish with it, as opposed to smaller fishing nets like whole exome sequencing. But unfortunately, the net may not hold as much fish, meaning that the technology of whole genome sequencing might not be able to finesse very large repeats or even other mutations that panels can catch. At least that's what I have read. So it's not always the go-to unless it is easily available, affordable, accessible, and the technology is available. The second thing I would say is when you have these questions about sequencing and testing, it is so important to speak with a genetic counselor through your neurologist, because you need pre-test counseling, selection of the appropriate lab, and post-test counseling in order to appropriately interpret the result, but also to be prepared for mentally prepared for both a positive or a negative result. And this is important. And we do this in diseases like Huntington disease, which is another genetic disease. And there's no reason why we shouldn't apply this best practice paradigm to cerebellar ataxia. This is a good one too, very important. What do you think is the most hopeful available treatment for SCA3? One of the most hopeful available treatments for SCA3, I believe, based on what my reading, would be the antisense oligonucleotide treatment. What is antisense oligonucleotide, or ASO? These are tiny snippets of genetic material that are designed to attach to the genetic material in the brain to prevent its conversion to toxic protein. The issue with these ASO treatments is, how do you deliver them inside the brain? The brain is not easily accessible, and it has to be done through invasive means, such as injecting it into the spinal space, like you're getting an epidural, or when you are getting lumbar puncture, and directly into the brain in the intraventricular space where the cerebrospinal fluid is, which is very invasive. But anyway, so the delivery mechanism needs to be finessed, as well as the dose. But there's proof of concept of ASO treatment in other neurological diseases, such as Duchenne muscular dystrophy and spinal muscular atrophy, familial amyloidosis. So it's been effectively used, and these are FDA approved ASO treatments for these diseases. And I'm hoping that the same technology, molecular technology, can be used to treat diseases like SCA3. Now, this is a very large topic and we only have another 40 minutes. So there are several other treatments that are very promising, but I just picked one which I think has a lot of promise. Let's see, going back up above, information about spinocerebellar ataxia and multiple sclerosis, a relationship? No, I am not aware. That does not mean there is no relationship. It's just that I am not aware of it now. I have people in my clinic who have spinocerebellar ataxia and multiple sclerosis. So I don't think there is a connection right away. Unfortunately, having a spinocerebellar ataxia or SCA, does not make one immune to other neurologic and systemic diseases. And if people with spinocerebellar ataxia have diabetes, high cholesterol, obesity, they can be a risk factor for stroke and heart attack, etc., which are treated separately. So what I'm trying to say is two diseases can coexist. Eric also says the interaction between oligoclonal bands in cerebrospinal fluid or white matter lesions in MRIs of the brain and spine. It's a very technical question. Oligoclonal bands, for the audience, are antibodies that are manufactured within the central nervous system space that are a marker of immune-mediated dysfunction, very commonly seen in multiple sclerosis, but not commonly detected in spinocerebellar ataxia. So I'm really not sure about the connection between the two. And I have a few people in my clinic with SCA8 who don't have oligoclonal bands in their serum, at least. And Stephanie's already answered Kunji's question. Laddie says, is reading an MIT technology review, and they mentioned an amazing drug molecule called Isrib. Had the name wrong before. I was wondering if you ever heard of it. If so, what can you tell us about it? No, unfortunately, I have not heard about it, Laddie, but I can do my research about it and perhaps send that research to Stephanie or to Lori, and they can share it with you. Robert says, I'm a 60-year-old person with SCA2, can no longer jog and find driving uncomfortable. A brother is 59 and SCA2, but he jogs and feels comfortable driving through, but also slurs words. Why do I seem to have more symptoms than him? Again, a very good and very important question. Spinocerebellar ataxia 2 is one of those triplet repeat disorders. The mutations amongst siblings can also be different in the same household, although you're only a year apart. It is not common, but it is entirely possible. Secondly, there is something called epigenetics, which is although two brothers may share a lot of the parental chromosome, they have their own individual genes. That's why, unless you're absolute maternal twins, you don't look the same. Two brothers can look very different in the same household. That can modulate the disease. So one person may have more symptoms than the other brother. So there's not just one factor. We do know that the numbers of repeats in a disease such as SCA2 does influence the severity of the disease and the age of onset, with larger numbers repeat causing earlier and more severe disease. So it's not a simple question to answer unless the repeats are looked at and until other genetic influences are also determined. Neuropsychological rehabilitation, Andrea asks, how can patients get access to this type of care? Are there specialty centers that focus in this area? Well, what is neuropsychological rehabilitation? Some people also call this cognitive remediation. It is to improve cognitive processes. It's studied most in traumatic brain injury, not so much in the ataxias, but what I'm pretty sure the principles can be applied to the spinocerebellar ataxias. in order to access this, you'd have to have access to a neuropsychologist who is trained in cognitive remediation and neuropsychological rehabilitation. And in order to find one, you'd have to work with your local neurologist or even the Neuropsychology Association, or number three, even reach out to the National Ataxia Foundation. But I'll tell you this though, I've been doing this a long time and there are not too many people who do cognitive rehabilitation unless they're working for a TBI or traumatic brain injury center. So it does involve a little bit of search on your part in order to find someone who can do rehabilitation. To make the search easier, you can get a neuropsychological test, which I do in people who have cognitive impairment, and pose the question directly to the neuropsychologist whom you are communicating with on how and where to get cognitive remediation. Even if you cannot get it, there are many things that you can do under the guidance of your local neuropsychologist that can help rehabilitate your brain and improve cognition. Lee says that she has been tested for several ataxias and they have all been negative. So at this point, Lee, I would still take the numbers that you've put on the screen to a genetic counselor and determine if whole exome sequencing would be the next best test for you, or would it be whole genome sequencing? And I would think that based on the numbers that you have put up over there, you've been tested for so many different ataxias, whole exome sequencing might be the next best thing, because it looks like you've been tested for triplet repeat disorders, which is the first thing we always do. And yes, so, but please do this under the guidance of your genetic counselor. Peter says, can you say more about retraining your brain or dealing with balance issues? Does retraining apply to speech issues? Yes, retraining the brain through neurorehabilitation involves multiple physiotherapy-related exercises, but you have to speak to someone who is knowledgeable about that. Speech can be retrained too, and we do this not only in the ataxias, but also in Parkinson's disease. We've got a program called Lee Silverman Voice Technique, which we use in Parkinson's disease. And I have seen the benefits of retraining the brain with intensive physiotherapy in ataxia personally. In fact, although we don't have a drug to treat ataxia's motor symptoms, it seems like intensive physical therapy makes a remarkable difference in SARA scores. SARA is the rating scale, scores and motor scores. The issue, however, is that the results are not long lasting after you stop training or stop your home exercise program. So you'll have to keep at it, which becomes challenging as the ataxia progresses and you develop weakness, you develop spasticity, neuropathy, etc. You cannot train at the same intensity when you have milder symptoms, but nonetheless, you have to move to keep moving, and that is the fundamental tenet of retraining your brain for both motor movement and for speech. Payson says they were falling down for 8 years sporadically and on a cane. They were on opioids. Been diagnosed with gluten ataxia. I see. So unfortunately, accidental exposures and the issues return with a vengeance. I see. Yes. So gluten ataxia is considered to be an immune-mediated ataxia due to a immune sort of reaction against gluten, the protein in wheat and other grains. And again, I read about it more commonly than I diagnose it. The diagnosis of gluten ataxia is best made by testing the entire celiac antibody panel. I use the Mayo Clinic website. They have a wonderful algorithm on how to interpret these tests because they are quite complex. Sometimes there might be one antibody elevated and the other might be suppressed. So the Mayo Clinic has a wonderful algorithm that allows the health practitioner to appropriately interpret the test. And if indeed there is an elevation of antibodies that are diagnostic of gluten ataxia, the first thing that you'd have to do, obviously, is a gluten-free diet, which is a challenge. So if someone needs a gluten-free diet in my clinic, I immediately team them up with a dietitian. That is really important because there are several grains that you may not, that you may think don't have gluten, but they do. So that's number one. Number two, there is a role, although not FDA approved, for medicines such as intravenous immunoglobulin for treating severe cases of gluten ataxia. And ideally, once gluten-free diet and the IVIG is initiated, the disease should not be progressive unless there is another ataxia. So it's also important to remember that gluten ataxia may coexist with other genetic ataxias, and there has been suggestions that perhaps people develop celiac antibodies in the setting of other spinocerebellar ataxias, and they can be elevated. So it'd be important to look for other kinds of acquired ataxias as well if the ataxia is continuing to progress with a gluten-free diet and with IVIG treatment. The CRSCA, okay, that's a really good question. And that's a fantastic question for the NAF. The NAF has a website for all the CRSCA approved sites. Why is spinal fluid important for research? Spinal fluid is the closest you can get to studying the brain in as non-invasive a fashion as possible. The spinal fluid is generated by the brain to basically carry nutrients and other important substances throughout the brain and spinal cord. It washes over all the crevices of the brain. It delivers nutrients. It removes gunk and delivers into the lymphatic system, and it's drained out. Studying the chemistry of the spinal fluid gives a very good idea of what's happening in the brain, but not in every disease. This is very important to remember, that in spinocerebellar ataxias, the spinal fluid could be bland, when we are using the usual tests. But in CRSCA, they may be looking for components in the biochemistry of the spinal fluid that have yet to be discovered, and using other techniques to look at the chemistry, which can give a clue into what do these genes do. Do they cause, what kind of neuronal damage are the genes causing? What kind of chemicals are increased or decreased in spinal fluid? So we are not using it to diagnose SCAs or even treat SCAs at this point, but I do believe that's the reason why spinal fluid is being collected, and it is really important for research for those reasons that I stated. Do programs with brain HQ aid in rehabilitating or retraining brain pathways? I'm not entirely familiar with what brain HQ is, but if it is based in neuroscience, if it is based in neurorehabilitation, then it should be useful. I also want to pause here and talk about sensible exercise. It is important that, that we exercise, all of us, but it needs to be done sensibly. And every exercise program needs to be, or brain retraining program needs to be customized for every individual, because you don't want the exercise to cause damage to joints, to your nerves, to your tendons, to your musculoskeletal issues. Sometimes we overdo things as much as we underdo them. We can become exercise fiends and cause wear and tear. So whatever you guys do in terms of rehabilitation and physical exercise, please remember that it needs to be sensible, guided, and therefore I'm a huge proponent proponent of neurorehabilitation, where the physical therapist actually takes your body frame into account and customizes a treatment for you. A company called Trellos announced that their medicine, Trellos, is accepted by FDA new NDA and grant a fast track designation. As far as I know, Trellos is in clinical trials right now, and there might be a fast track designation for this particular sugar, it's a sugar compound. And how can we see it on the market? You won't see it in the market outside of the orphan drug designation unless the clinical trials are successful. So marketing is very different from getting it directly through the company as an orphan drug. That's important. And when I did my research for this particular seminar this morning to look at Trellos, I saw that it was still in clinical trials. Orphan drugs are important, but one caveat with orphan drugs is thus, and we found this in some of the studies, including the MSTAR study for multiple system atrophy, is you can get the drug off-label as an orphan drug in the middle of a clinical trial before the clinical trial is over. But if the clinical trial is not successful, there is no guarantee that you will continue to get the medication from the company. And therefore, I am a little cautious about giving any drug outside of a clinical trial to people, because if the drug is working, number one, you may be deprived of an opportunity to get it because it may have not worked in a clinical trial. And it's kind of cruel to then take the drug away from people because the company's not going to manufacture it because the clinical trial failed. And number two, one of the lessons we learned from Parkinson's disease is the lesson of nicotine. Nicotine or tobacco smoking is supposed to decrease risk factors of developing Parkinson's disease, but the nicotine trial failed. And I'm not sure what nicotine does in each individual people, but not only did it fail, it actually showed a deterioration of symptoms. So one needs to be very careful about getting drugs from through the orphan drug state, because you may have side effects that you may not be able to monitor outside of a clinical trial. Thank you, David. Can you provide a link to the Mayo Clinic website you just referenced? Sure. You want me to pull it up right now, or can I send it to Lori? Okay. All right. I'll be happy to send it to Lori, and Lori can share it with all the participants. That's right, Peter, keep moving slide. Use it or lose it, you're right. Lori put up the CRSCA website. What is the difference between ataxia and MSA? Ataxia is a very generic term, and it is important. I'm so glad you brought this question up. Not everyone with ataxia has a spinocerebellar ataxia or has a genetic disease. It's a catch-all term. It's not a diagnosis, it's a description, and in Greek it means incoordinated, basically. All cerebellar ataxias have ataxia as a component, but not all ataxias are from degeneration of the cerebellum and its pathway. Sometimes you can get sensory ataxia in diabetes, which happens as a result of neuropathy. When nerves in the feet are affected in diabetes, they don't send appropriate signals up your limbs to the brain to process, and as a result of which you become incoordinated, particularly in dimly lit surroundings with your eyes closed. That is not the kind of spinocerebellar ataxia that we are talking about. That's called sensory ataxia, and it's called ataxia, but it's got nothing to do with the cerebellum per se. MSA, multiple system atrophy, is a neurodegenerative disease. It falls under this large umbrella or rubric of Parkinsonism. Parkinsonism is, again, like ataxia, a description, and multiple system atrophy is it has a link to ataxia because it can be of two different types. MSAP and MSAC. Multiple system atrophy C or cerebellar causes more ataxia than Parkinson's symptoms. So there are two different words. MSAC is a disease that can cause ataxia. A cerebellar staining, I suspect that was cerebellar training, and I think I've already spoken about retraining the brain, and that speaks to the neurorehabilitation and exercises that I spoke earlier about. Marta says that her brother cannot digest what he eats. There's a lot of vomiting going on. The smooth muscles do not contract. What should he do? Oh, this is a very challenging situation. I'm very sorry, Marta. The first thing that one must do, and if it's not done yet, is to ensure that a gastrointestinal specialist has been seen to make sure there is no obstruction in either the upper GI tract or the lower GI tract. If that has been already ruled out, and then you can proceed with supplemental nutrition. And this brings us to diet and ataxia. Typically, ataxias don't cause this degree of nausea and vomiting. It would depend on the kind of ataxia he has. So number one, see a gastrointestinal specialist to make sure there's no blockage, there's no ileus or stoppage of peristalsis, which is a contraction of the GI tract. That would be the first thing. Second is to ensure that you are seeing a dietitian counting calories, because if he's vomiting so much and not absorbing things, he's probably malnourished and losing weight and deficient. So at that point, you may have to talk to your treating neurologists about tube feeds. This is stability. This doesn't treat the underlying issue, but at least in the meantime, the person gets the calories they need. And so you'd have to partner with your GI specialist, your neurologist, and the dietitian to come up with a plan to ensure he's getting the calories he needs, while you're working with them to determine why are the smooth muscles not working. Is it due to the ataxia or is it due to something else? And very importantly, if you're not getting answers where you are, this is the kind of time, this is the usual complicated sort of issue that you would take to a world renowned ataxia center. And depending on where you are, and there are lists of 10 or 12 very prominent ataxia centers in the US, and Lori can give you the list. They are posted on the National Ataxia Foundation. These ataxia centers implement what is really near and dear to me called multidisciplinary care, where the ataxiologist partners with the internal medicine doctor, with the GI doctor, with the dietitian, with the nutrition counselor to determine what is the best way to treat the nausea, the vomiting, and get appropriate calories in. Thank you, Peter. Has there been any research into medications like adderall to help with cognitive issues that arise from the SCAs? I'm sure there are. If you go to the that website that I mentioned earlier, I think modafinil and a couple other drugs were studied earlier in small numbers, but they didn't show a signal in the cognitive sort of realm in the ataxias. These medications are used off-label for not for cognition as much as it for fatigue and for excessive sleepiness. And so at this point, there is no room for using these medications in everyone with cognitive issues, because these medications have their own potential side effects. I would partner with a neuropsychiatrist and a psychiatrist to determine if medications such as adderall and modafinil are needed to improve sleep, sleepiness, fatigue, etc., which are very common in the spinocerebellar ataxias. how hand and voice tremors caused by ataxia, how can you treat them? Well, hand and voice tremors are common. Hand tremors in ataxia are different than the most common tremor in the world, which is essential tremor, but we have successfully repurposed those same medications to treat hand tremors. The tremors caused by ataxia are different in the sense that they're caused by muscles that are closer to the shoulder than the muscles that govern hand movements. And these tremors can be difficult to treat and challenging because they're caused by large movements of these muscles. The medications we use to treat essential tremor can be used to treat hand tremors. There's also a suggestion that if large muscles are involved, Botox or chemodenervation can be used to quieten those muscles down, but it needs to be used very carefully because it can paralyze muscles. Voice tremors are much more challenging. Speech therapy would be the first thing to try. The medications that can treat hand tremors can also, in a small number of people, have benefit for voice tremors. Lastly, some people have effectively used chemodenervation or Botox in the vocal cords to treat voice tremors, depending upon the quality of the vocal cords. But this needs to be done under an otolaryngologist's guidance and under their supervision, because it is not a treatment without risk of dysphagia or swallowing problems. Serodist, again, I'm very sorry, Esbalia, that I don't know what Serodist is. It's not a medication that is used here. I do know that there is a medication that is used in Japan, which is an analog of the thyrotropin-releasing hormone TRH, which is being studied here as well. It's been available in Japan for the treatment of ataxias for a very long time, but I'm not sure if this is the same medication. So I apologize. I don't recognize that name. Let's see, can you give, this is asked earlier, a follow-up question on, for ASA, will it be a one-time treatment? That is so important. I don't think so. And that's exactly what the research trial is going to determine, is what is the dose? How many times does the ASO need to be injected in order for it to work? Can the ASO be taken by mouth, or does it need to be injected? I doubt it's going to be a one-time treatment. I know University of Washington will start to do a phase 1 clinical trial on it. Yes, Dr. Marie Davis, I believe, at the University of Washington is also an ataxia expert, a wonderful neurogeneticist, and I do believe she's planning to do the phase 1 SCA3 trial with ASO, so stay tuned, folks. Just going to ask Lori, I might be at the end of the chat as I'm scrolling. Are there any hands I need to answer?
It looks like we have covered everything in the chat. Thank you so much for the wide range of topics that you've covered in answering all of the questions today. I do not see any hands raised at this time.
Okay.
If you have a moment to find the Mayo Clinic website, I'd be happy to pop that in the chat.
You're talking about the gluten ataxia?
Yes.
Okay, I will do my best to find that for you guys, and then I'll come to Linda's question.
Oh yeah, Linda has a great question.
Yep. I found one website, and here we go. And send. And let me see if I can find the algorithm, because that was, I think it's Mayo Clinic Labs.
Well, thanks for popping that in the chat there.
Oh, you bet. I hope you can disseminate that while I'm looking for the algorithm. And that actually has tabs that you can tap through: Mayo Clinic Labs, Gluten Ataxia. Yeah, it's called the Celiac Disease and Gluten-Free Cascade. Now I'll pull that up. All righty. And so this is the main website to Mayo Clinic Labs over here. And that takes you to the tabs that show you the cascade. There are several PDFs attached. It's called the Celiac Disease Comprehensive Cascade and this Celiac Disease Diagnostic Algorithm. And I'll send you the algorithm in just a second. There we go. And I think those three websites should cover it. The last one takes you directly to the algorithm. All right, and now I can go to Linda's question. Let's see. Cystoscopies. Cystoscopies for treatment of ataxic bladder incontinence. A cystoscopy is a scope. It's a bladder scope, which a urologist or a urogynecologist does. It is done for many things. The cystoscopy doesn't specifically treat ataxia bladder or incontinence. It is a diagnostic tool. It can be a treatment tool if the bladder is flushed with chemicals or medical medications in order to treat incontinence. But it's not very commonly done. It's more diagnostic than it is treatment for incontinence. The bladder has two functions: storage and voiding. And in ataxia, you can have a problem with the storage, or you can have a problem with the sphincter, which controls the stream of urine outside the bladder, or both. So there are different medications that are used to allow the bladder to store urine appropriately before the sphincter starts firing off, which can cause urge. So you keep going to the bathroom even when the bladder fills up a little bit, and that causes that urgency and that frequency. And then the other problem is the bladder does not contract, and probably it just becomes flaccid. And the urine keeps building up, and that is actually dangerous because the urine can back up and cause upper urinary tract dysfunction, and that's called an atonic bladder, and that's a little more difficult to treat unless you do self-catheterization. The third problem is the bladder and that sphincter are fighting with each other. The bladder wants to store, the urinary sphincter wants to void, and the bladder wants to contract, but the urinary sphincter doesn't. This is called, it's called a neurogenic bladder, or it's called dyssynergia. In that case, medications are available to quieten the bladder and the sphincter. But the cystoscopy per se is a diagnostic procedure, unless medications are delivered through the cystoscope. Let's see. Yes, percutaneous tibial stimulation is one of the treatments for this detrusor sphincter dyssynergia, DSS, and it is a very generic, general sort of a treatment, not specific to ataxia. If the bladder incontinence is due to the sphincter dyssynergia, in which, or due to an ataxic bladder, which is not contracting, then the tibial stimulation can help. But the urologist always does a trial before they actually prescribe it to you or implant it in you to determine if it is working or not. But yes, it does have a role in specific types of bladder dysfunction, either the storage or the voiding, but it needs to be done under urologist's guidance. And it's a sort of an avant-garde out of the box treatment for bladder-related concerns, not just in ataxia, but in various other neurological diseases. Let's see. Thank you, Louis. Thank you very much. Oh, SCA 42. Don't have anyone with SCA 42 in my clinic, but now that we're up to 48, I'm sure I'll be seeing people in the 40s. The troubling symptoms are speech, slurring, and focus while speaking. Memory and balance. This is what Coy is talking about are both motor and non-motor symptoms of ataxia. Motor symptoms of ataxia include eye movement problems, speech, dysphagia, incoordination, balance, tremors. The non-motor symptoms include the cognitive issues which Dr. Schmamann has talked so eloquently about in his webinar, the cerebellar cognitive affective syndrome, which can involve memory problems, mood problems, behavioral issues, etc. How do you determine if these issues are either from my age or ataxia? As a 50-year-old, typically aging should not cause troubling symptoms with speech, slurring, difficulty with focusing, etc., memory and balance. Most likely these are related to the spinocerebellar ataxia if the diagnosis is firm and confirmed. And how do you address these medically? If I decide to address these medically, is there a difference? And I suppose the question is, are there different treatments for it? Yes, speech is speech therapy, memory is cognitive rehabilitation, but first it's important to get a baseline memory test through neuropsychological testing to see where you are and then go from there. And balance, we talked about balance retraining the brain. So if you have this comprehensive program, you can improve your speech, you can ensure that cognitively you are doing tasks that strengthen your memory, and then for balance you have neurorehabilitation. Let's see. Ms. Jaya, trying to find a group from my 31-year-old daughter that can provide adequate care for her FA. Any suggestions? Oh, fantastic question. You're in the right place. Lori can connect you with FARA and with NAF, and we have very strong connections with the Friedreich's ataxia community. In fact, a majority of the trials clinical trials that are being conducted in my research were in the area of Friedreich's ataxia. So Lori, will you be able to help Ms. Jaya find a FA support group?
Yes, it's looking that she's trying to find a group home for her 31-year-old daughter.
Oh, it's a group
so it
home.
might be housing versus
okay.
treatment. So I think for Ms. Jaya, I would recommend connecting with your local independent living center for some suggestions there. And I can plop in a website on independent living centers into the chat.
Yes, and yesterday I saw a patient with SCA2 who needed a group home immediately, and also a full care assist facility. And my social worker came to my rescue.
That's a good resource as well.
If you are able to connect with a social worker through your neurologist's office or your primary care doctor's office, they would do an assessment of your daughter and determine what is the best living facility for them in your area. And if it's a group home in the area, I'm sure they will be able to help you. So how do you go about doing that search? Many ways. Number one, connect to NAF, connect to FARA, connect to your local ataxia FA group, because I can tell you the NAF community is so savvy. The best part about belonging to the NAF community is how much we learn from each other. I mean, there are already questions on this chat I cannot answer, like serodist, etc. This makes me want to go and learn more. So this is a bi-directional sort of an activity in which I'm learning as much as I'm disseminating information. So please connect with those resources. Sorry. Help me. Okay, thank you for sharing that, Peter. How much the coordinated therapies, peer counseling, and psychotherapy has helped you. Marjorie says nystagmus is a symptom of cerebellar ataxia, very common, and there are treatments for it, by the way. So this is an excellent question. The treatments for nystagmus include eye training therapy, which can be done through a trained a PT who specializes in eye movements, number one. Number two, there are medications that can help. There are several. There's gabapentin, there is chlorhexazone, there's clonazepam. There's a long list of drugs. Not every drug works for everyone, and the drugs can have side effects. So either I initiate the medication and go down the list to determine which helps for nystagmus, or I send my patients to a neuro-ophthalmologist, a neurologist who basically deals specifically with eye movement problems, including nystagmus. And nystagmus is treatable. It's not always treatable 100%, but it can be treatable to the point where it does not become very bothersome. And it's an exercise. The first medication doesn't always work, but the treatment should be initiated. Not as much for nystagmus, but for double vision as well. There are prisms that can be used. So eye movement problems in ataxia are very challenging. They can range from a decrease in vision due to retinal problems in diseases such as SCA7, and also problems with the movement of the eyes themselves. Challenging but treatable. When one treats negative for everything and has been diagnosed by symptoms alone and cerebellar atrophy, is it possible that it is something else? Well, it is cerebellar ataxia if there is ataxia and cerebellar atrophy. If you put those two together, that becomes a cerebellar ataxia. I don't know if one can test for everything. That is, there are so many different neurological diseases that can affect the cerebellum, both acquired and genetic, that testing for everything is likely not possible. We test for things that we think are most obvious based upon the exam. It could be a condition other than genetic ataxia, such as an acquired ataxia. There have been instances in which people have been affected by viruses. They've been sick from it due to the flu, also due to COVID-19, etc., which have caused cerebellar disease and damage and have left people with cerebellar atrophy. And viruses are very difficult to detect after the fact. And sometimes even during a viral illness, it's difficult to recover the virus from the cerebrospinal fluid. So there are so many causes of cerebellar ataxia that if you feel that you're not getting anywhere with testing, please see an ataxia expert. There is a group of diseases which we call idiopathic late onset cerebellar ataxia, or ILOCA, which is a wastebasket term for cerebellar ataxia without a diagnosis today. But there are a lot of diseases that were called ILOCA 10 years ago, for which we have a diagnosis today based on expansive genetic testing. Thank you, David. I appreciate it. Thank you for attending. Ataxia and driving concerns, yes, very challenging. Ataxia can cause spasticity, eye movement problems, weakness, and neuropathy, which can all cause problems with driving. In order to determine whether you're fit for driving, two things can be done. You can actually do a driving test, which I tell people to do, which is a lot of cumbersome, but they are driving simulators that can be used to determine whether your reflexes are intact. They do not always 100% recapitulate what you do on the road, but you can get as close to learning whether you are fit to drive or not. I'm going to stop here because we are a minute from the hour, and we have got several new questions that I'm so sorry that I won't be able to address in a minute.
Well, thank you so much, Dr. Khemani, for all the questions that you were able to address today. We really appreciate all your time. And thank you all out there for joining today's Ask the Ataxia Expert session. We hope you join us for next month's session. And we hope you all have a very happy holidays out there and take care. And a recording of today's session will also be available on our website. So good night, everyone. Have a great weekend. Thank you, Dr. Khemani.
Thank you. Be well. Stay well. Take care.